All right, ladies, well, and gentlemen, if they're there, welcome to this is our next high tea. We're going to look at a case history today that is about silver fluoride and the armor approach when we're using a hypomineralized teeth. Now, we did one a couple of weeks ago where we were looking at hypomineralized teeth, but there wasn't a lot of post-eruptive breakdown. This is a case where there is a significant post-eruptive breakdown before the patient came to see me. And so what we're going to do is, I call it a stepped approach, because you really, when you get these children in and they're already got their breakdown, and oftentimes they're quite young, dealing with hypermineralized teeth can be fraught with all kinds of sensitivity issues, mental and physical. All right. So in December 2018, this little girl came and her parents noticed a hole. She had sensitivity to cold, but the parents did not realize that this was a tooth that was a permanent tooth. So the other teeth that had begun to come through had mild hypermineralization, but certainly no post-eruptive breakdown. And the tooth 6 had very early breakdown. It was one of those ones where you're really not sure whether it's breaking down or whether it's just really quite weak. But the main problem was this tooth 6. Now, because they're a little bit in shock that it was a permanent tooth, it was December, late December. It was the week before Christmas. There was not a lot of preparation time where people were going on holidays and things like that. So we talked about the options for treatment. Because she was only 6 and this had just erupted, she had not really had any other dental treatment before. We had to go through the options, and of course that probably was going to include a local anaesthetic who were going to do a proper restoration on this tooth. Now, the other alternative would be to just pack it with a GIC. My preference in this case, but I presented it as an option, was to just start with a silver fluoride treatment to deal with the sensitivity, because there was some active caries in there, and we wanted to make sure that the caries that was there was treated before we started putting a filling material on top. And my previous experience using silver fluorides in this manner meant that this was going to be the one that I felt was going to actually give the tooth the best long-term outcome. So I used the chairside assistant, the hypermineralized chairside assistant, to explain to the mum. And also too, because these were quite well-educated parents, they wanted to do their research on silver fluoride and everything like that, and that's fine. But she said, look, let's just do that one tooth that's giving us the problem. We'll deal with that one today. And then when we come back, we'll do our homework and we'll come back, which is a fair enough proposition. They knew then that they were actually dealing with the problem that was presenting in this tooth, and we weren't ever going to lose ground by doing that. So I gave them also a take-home pamphlet from the ARMA website that I either email or I print off and give to the patients, so that they can take that home and explain to the other part of the parenting party that there is this is where we're going with this, and they were then able to do their homework. So that day we applied CSDS. We did the 3 minutes, and then the stannous fluoride, and I put some Durafat as a holding material over the top of that tooth. And then in January 2019, and it was late January by the time they could get back in to see me, so it was around about a month later, this is what the tooth presented and was looking like. So all the symptoms that they had presented with had disappeared. They were really happy with that. She was actually able to eat ice cream and things like that same day. So within that day, the symptomatic sensitivity, which is what brought them to us in the first place, apart from the visuals, is that was all resolved. But I could see that this was not fully arrested. I couldn't blow a lot of air on that tooth the first time around because of the sensitivity. So with hypomineralised teeth, I almost always in this situation, I do a second application. And I had told them about that at the very beginning. But what I like to show you here is the photograph that this area around here, you can see it's not jet black. There is an element of blackness, but it's still not what I would consider arrested, fully arrested, and certainly not fully remineralised. And so at that visit, all we did is we put the CSDS application back on there again. But I was able to get a bite wing at that visit. I didn't do one the first time because she was 6 and it was all very new and she was a little bit worried about what was happening. But you can see down here, this is the depth of the caries. It was not hugely close to the nerve of the tooth, but it certainly would have been quite sensitive to restore had we not used the CSDS in the first place. Now, when they did come back, they had done their research and they had considered all their options and they said, yes, this is the way we're going to go with all of the other teeth as well. So we were able to move towards that. So that was the second visit that we did. And then on the third visit, which was a week after that first, the second application, this is what the tooth presented like. What I like to gain is that each time we get the children in after we've treated them with silver fluoride in the hypomineralised realm, we are getting better and better photographs because we're able to blow air on them. They're more comfortable. We're able to get a much better clinical photograph than we did at the beginning. And that's a testament to, I think, how comfortable the children are getting. But you can see the difference in the blackness there. It's really quite black. And at this point in time, what we were doing is we were just putting the CSDS right around here. We weren't sort of doing the whole tooth at that time. And what I was able to do on that visit is, you know, we knew that it was arrested. The colour told us that. And the whole thing with the CSDS is the caries status disclosing solution, which means if the caries is black, we know it is arrested. And so we were sure then that that had happened. Obviously, there was no sensitivity. And what I did is I just got a round slow speed burr and I just cleaned out the black callus. Now, if anyone's done that, you'll know that that kind of lifts off quite easily and it comes out like burnt toast, and that's why we nickname it burnt toast. And I just also I got a flat fissure high-speed burr and I just tidied up some of these edges. I didn't go and extensively make it a really nice round hole because hypomineralised teeth don't need any extra help to break down, and so I just made sure the margins were sound and cleaned. And we established a thing called crydentinea. And the crydentinea is where, when you're cleaning the tooth and you're using like a spoon excavator, you can hear that scratchy sound. That is a sound which has a name, and it's called the crydentinea. And so when you have that establishment, you know that you are down there in arrested I keep on saying arrested caries, but it's actually you've taken the arrested caries off because that's a bacterial mass. But what you've actually got now is arrested dentine, and that's what we were left with. Then we were able to put the GIC in. So we did that with no local anaesthetic, no discomfort. We had that crydentinea established. But the other thing that we had done is we knew straight away that tooth was not going to continue to break down underneath the GIC because that GIC was going onto really sound tooth tissue. And so at that second visit, I was able to then start working on the upper tooth. So, you know, the one I said that was kind of breaking down, but you really weren't sure, that was where we were with the 2.6. So I put the silver fluoride on that at the second visit, and at the third visit, I was able to fix that one up as well. When they came back in February 2020, so that all happened in February 2019, 2019. They came back in February 2020. I had seen them in the meantime, but I got these photographs at the 2020 recall, and you could see the GIC was still very much in place. The tooth was much more erupted. GIC had discoloured a little tiny bit, but this tooth was fully functioning. The GIC is not breaking away though, and it's more of a wear down. Now what happened here is then she was complaining 12 months later of very slight sensitivity on the tooth, but it wasn't around here, which we had already dealt with. It was more around these margins. And hypomineralised teeth, as you know, they can have hardly any breakdown, but be quite sensitive. And then sometimes they could be really broken down and really not have a lot of sensitivity. And so what we were looking at here is to desensitize all of the rest of the tissue to take care of any of that residual sensitivity that was not associated with the actual lesion. So I covered the whole tooth in CSDS, and put a Durafat over the top. And the Durafat, again, is just the holding material. And I did the same to the top tooth. And I will be taking more photographs when they come back for their recall. What I'm expecting to see in that is maybe a little tiny bit of dark staining around here, but the rest of this tooth is normally doesn't go black at all. But the follow-up photographs are going to be really interesting to see. But I guess the main thing is that in this case, the child, this is the top ones here, the child is eating normal diet. The teeth are not breaking down, and we're not losing ground with any of that. I took a 12-month recall photograph. So this is where the decay was originally and the extent of the lesion down here. And you can sort of see here where the tooth has the line of remineralisation. That's really quite defined there. And so we certainly have saved that tooth from a lot of further breakdown. Parents are really happy even with those little discoloration things. They know this is a permanent tooth. They know that something can be done with this later on. Now, whether that is justifiable to take that tooth out to let the 12-year-old, the 7 or the 12-year-old molar come through is up to the orthodontist. However, if we can keep that stable from the age of 6 to 8, the chances of that tooth being maintained long term is really going to be high. It may need a crown later on, but you still have that whole tooth there, and she may avoid the complex orthodontics that would be needed. That's not my call, but at least we're setting her up for success there. So what I like to do is use this armor approach when we're doing this with the patients to take them through the journey of what we're doing and why. We're assessing the arrest and we're reviewing the remineralisation first up. Then we work out how we're going to manage that tooth. Education paramount to everything that we do. Education on hypomineralisation, why it was like this, that they're going to be high maintenance teeth, that it might be simply putting CSDS on them from time to time just to deal with the sensitivity, and then perhaps later on have a full crown done. The tooth will guide us there. But, at least we're giving the patient something to work with along the way. So your restoration is basically up to the clinician and what you're going to be doing and the long-term plans for that tooth. Basically, again, you're re-establishing optimal oral health and you're rehabilitating that tooth and the rest of the mouth. So that is the presentation that we have for that. And if anyone's got any questions, then fire away.
That was really good, Kath. It's a bit similar to the other one that you did, but there wasn't the breakdown there.
No.
And
no.
I think what I like and what I mentioned earlier, that it's just feeling more confident that that tooth, now it's remineralised, that, you know, there's more success there. And you just feel more confident that that tooth is going to have a more longevity. It just, you know, you're not as concerned about it. The patient's happier. You've given them, or the parents, all the education, but it's peace of mind as well.
It is. And I think the other thing too is you're not afraid. In the past, you know, when you have kids in with hypomineralised teeth, you're always scared about where they're coming from, what their, you know, what their future, dental future is going to be like. What are you going to see? How much breakdown you have to see? And I've used, you know, many materials over the years. You know, the Fuji 9 extras and the Fuji 7s, Fuji 7s were lovely, high fluoride. Yes, you got remineralisation. It took time, but you had to get that material to stay in the tooth. And it wasn't always fun because the tooth began to break down around the restoration. And what I like about this technique is you are dealing with you are managing the caries process, but you're also remineralising at the same time and desensitising it. And I think that it's a win-win for the patient, because the patients are not scared to come back either, and that's really important.
Have you done any on like distals of D's or E's as well?
Oh, what with this with hypomineralised, or just regular?
Just regular.
Oh yes, that's my bread and butter. Yes, definitely. And the results are the same. So I use it basically wherever there's caries. I tend to use silver fluoride to manage the caries, promote mineralization, and then I'll go and I'll treat the tooth. Because and where there's been a breakdown in the marginal ridge, and where people used to sort of say, once there's a breakdown, you're on the way to the pulp. You know, no, it's not like that anymore. And the caries may have been on the way to the pulp, but you can certainly stop that. And you know,
so even if they have symptoms of pain, which can be sometimes food impaction, but
yes, if it's food impaction pain, yep, that's not a problem. If it's just occasional, you know, cold sort of stuff, if it's signs of irreversible pulpitis, no, that's not it. Although I have had some wins there, sometimes it's worth giving it a go. Because what I find that apart from anything else, you know, if you treat that tooth and you are reducing the sensitivity and you're doing that, then you can clean up the rest of the mouth really well. And if that one does not turn out successful, the child is eating out of your hand to have the extraction or whatever's done. I mean, if it's irreversible and it's pulpally involved. I mean, if it's a clear pulpal involvement, obviously no, you go straight to your traditional treatment. But you're sitting on the fence. I can tell you the amount of wins that I've had that I've been surprised with has been amazing. Yeah. I mean, you have the occasional loss, but at least the parents know that you've been sailing really close to the wind. The kids are really happy to come back because you've been really nice the first time, and you've managed to clean up the rest of the mouth. And if you're looking from a holistic treatment point of view, and you're looking at the whole rehabilitation of the mouth and education of the patient, it's not going to happen in one visit. And that's the way I tend to go. So
and I was going to say, with the as you're saying, a holistic approach, that once you've treated these caries, and as you say, nothing can be done overnight. And it's so good to be able to manage, stabilise, and then work on all the education and home care and get things back on track.
Yeah, because that doesn't happen in one visit, you know, especially when the children are presenting with, you know, large lesions. If they've got large lesions in any of the teeth, not just hypomineralised teeth, I don't go straight for the you know, I don't go straight for the education side of things. Okay, we've got to deal with what's in front of us. You've got minimal time. Talk about the tooth. Talk about the decay. This is what they've got. It's everybody knows they've got decay. Manage that decay there and then and there. This is how you can do it, Mum. You know, we can do this. This is going to stop the decay in its tracks. We are then be able to get them back, and we can start from a basis where we can start working our way around. And they usually go, oh, that's good, because they are often shocked and bamboozled. They don't want to be able to make decisions. Like this family in this particular case history, they weren't ready to dive into whatever we had, you know, to present. They needed time, and so that's why this was perfect for them. They could go home, they do their you know, research, work out where silver fluoride was in the world, because they were those kind of people, and we're really grateful that we had the opportunity to use that on their little one. And I think most people like that slow and steady and considered approach, rather than, okay, this is what we've got to do, this is what we've got to do today, which is usually take care of the pain or the, yeah, I mean, like if they come with a full-blown abscess, that's different, hey, but, you know, but at least when they do that and you get them back the second time, if you're using silver fluoride to gently bring them along again, then you can win them over. And these are children, not little adults. You know, they think differently, as you know, if you deal with children. Kate, you know all about that.
Absolutely. And also there's, you know, a lot of children that are on the spectrum of autism, and they need that care, and you need to take things slowly and condition them. So it's so non-invasive. That's fantastic. I find really, really good. And the other, so one more thing I was just going to say, because I'm in a non-fluoridated area, we have a lot of young parents coming in that have moved to the area that have strong teeth, they have no caries, and they don't understand it. They're shocked. So it does give them time to take it all on board and work on strategies.
Yep. No, it certainly does. I think that's a real, that's an important point for different people who live in different areas too. And the rate of decay is so fast. And I'm so glad what you were saying before, Kate, is that by taking those x-rays at the first visit, you're able to then identify the interproximal areas that are needing to, you'll be really surprised at how you can mitigate the progress of that caries. Yeah. Just, you know, even if you have to redo the applications a couple of times, you know, like at 12-monthly intervals or something like that, it's that they don't need the fillings, not near the fillings that they normally do.
I'm really excited about it, and yes, that's been the case. Of taking the radiographs, there's, you know, caries in all the primary molars, and it's just so good to identify that and address them this way and then manage it. It's been really good.
Yeah, it'll be nice for you to see them in 12 to 24 months down the track, and having a look at that side of things. So yeah, all right, okay.
Yeah.
All right, okay, have a good week, everybody.
Thank you. Bye.
Okay.
Bye.
Bye.